highlights we saw from the 8th Devolution Conference celebrating 10 years of devolution in the country. And what I mentioned, the president mentioning that within 60 days, the functions that are supposed to be devolved will actually be cascaded down to the counties, including health, which is a devolved function. What low-hanging fruits can the counties pick after this particular move is implemented in the right way?
So I think it's now more of prioritizing their resources based on the unique needs of the counties, because the needs of every county is not the same. So this will help just customize and address most of the urgent needs that county has. It will make healthcare even more accessible to the rural people, because they know they just have to go to their county and not travel all the way to Nairobi. It will also give an opportunity to train maybe medical fraternity to be able to take up those slots. It will increase employment for the doctors and the nurses and everyone in the healthcare space. It will also create an opportunity maybe to improve the infrastructure in that in the county.
Okay. Well, this is all pegged if the money is prioritized in the right way and is not wasted.
Definitely.
When we're hoping for such a move once this particular transfer of functions is done by the national and county governments. So certainly there's some key highlights in the state of cancer treatment in the country and how the counties actually manage this particular treatment. And let's put this all in the context of 10 years of devolved governments. And one thing you've mentioned is the localized decision making, because the priority perhaps of Busia County, as we've seen right there, might be the contracts of the healthcare workers. If we cross over to Kirinyaga, they recently built a level 5 hospital. So the priorities are definitely different. When it comes to cancer treatment and the empowering that comes with localized decision making, how will the fight against cancer be boosted? So
we will have even more awareness at the county level, and we'll be able to reach more people. Unlike when we've been doing cancer awareness on national scale, we are not able to reach the Wanjiko or somebody in Garissa or Western. So that is an opportunity. We'll be able also to really purposely set aside resources to build infrastructure. Because cancer as a disease is very complex. It involves expensive infrastructure, the equipments. You need specialized medical specialists to manage that unit. It also needs capacity building. We know that at national level we have a lot of capacity, but when you go to the county, we're still limited in capacity. So we can leverage on the national, say, teaching and referral hospitals, trying to reach out to the counties and holding their hands and helping navigate some of the critical barriers our cancer patients face. And these include economic barriers. They also include physical, like they are not able to travel from a far county to Nairobi. So all those are things that we'll need to work on.
Okay, and you mentioned something about the infrastructure, because cancer is, technical, if I may just borrow your words. So in terms of infrastructure, and this just borrowing from the previous government, we saw an agreement between the national and county governments to supply some of this machinery that is needed in hospitals. It didn't go so well, and we definitely saw the push and pull within that particular program. But when it comes to access disparities, because number one, we need hospitals, not just hospitals, they need to be well equipped to deal with certain medical challenges, including cancer. As it is right now, there are disparities. What should we do to ensure that, Wanjiko doesn't have to travel all the way from Garissa or a different county to Nairobi or to the Texas Cancer Center in order to get the much needed treatment? How do we devolve some of these functions in the right way to ensure that service delivery is not affected?
So every change has its own challenges.
Yeah.
And I think as much as people are focusing on the negative, we'll also need to focus on the positive. We know with the equipments that were sent to the counties, some counties have taken it very positively, and now a patient can get a CT, MRI in their own county. You don't have to come to Nairobi. But everything takes time. You know, for cancer, it's time bound. Like you need several years to build a cancer center, to equip it, to train a cancer doctor takes almost 10 years because you have to go through undergraduate and then do masters. We need to train oncology nurses. After their basic nursing school, they have to go to specialize. We have radiotherapists, we have surgeons, we have, you know, it is a whole spectrum of medical personnel. It is a multidisciplinary treatment disease, and it involves a lot of people who needs to be trained, and this will take time for us to stabilize those counties. But the good news is that we have several counties giving. We have what we call chemotherapy centers. For example, Mombasa, Garissa, Machakos, Nakuru, even in Kisumu, Embu. So those are just a few.
Yeah.
And then of late we have radiotherapy centers also in the counties. Starting with Nairobi County, I think that is the one that has the most because it started early in terms of investing in cancer as a county. And then we have Nakuru, which came up. We have Mombasa. Now patient can get radiotherapy in Mombasa and even in Garissa. So those are very good gains our government has done. But we still have a long way to go because this adventure is quite capital intensive and human resource intensive. Yeah.
Well, it's only 10 years. Many might say the baby is just learning how to walk, and we definitely need to give it more emphasis in terms of resources and the human resource as well aspect. Let's talk about cancer specifically and how important early diagnosis is and how we can perhaps build capacity within the counties to ensure that, number one, public education is of utmost importance and awareness campaigns are spread out across the 47 counties in order to address this issue, the issue of cancer within the country. How do we approach that?
So we need good statistics. So as much as we are developing this care, we need like a cancer registry. People need to report. We need to know what cancer is common, what stage, what are the challenges that these patients are facing. Case in point, we have the patient navigation program at Kenyatta National Hospital, which has been running for 6 years now. And through that navigation, we identified certain barriers that cancer patients face. One of them is just staying hungry all day when they have come for their treatment. Another barrier was financial. They didn't have money to pay for treatment and accommodation, because a cancer treatment takes a long time. It's not a one day, it can take several months. Another barrier we faced was just physical, navigating their way around in Nairobi and even at KNH. How do they do it? So based on that and through this patient navigation program has come in handy to help them overcome the barriers. And we've done this by encouraging patients to enroll on NHIF. So with that, at least the financial burden is taken off. We also reach out to well-wishers to pay for these patients. Even just NHIF is 6,000 per year. If you can reach out and pay for them, that already overcomes some of their barriers. And then knowledge gap. We have had to have leaflets explaining to the patient what your treatment entails, what your diagnosis entails. Before, patient never used to know this. You know, they are just referred to KNH, no one explains to them anything. They say the doctors are busy, they didn't tell me anything. But now we sit them down and explain to them the treatment, expectations, the duration. So when they say knowledge is power, when you know what you are going to go through, I think you are more prepared on the same. Also reaching out for accommodation. So with the counties, instead of a patient traveling to Nairobi, they can be commuting from their home to go for radiotherapy. and back. And then another thing is really we see that majority of the cases are presenting in stage 3 and 4. So this leads to very high mortality rate. So we need to do to reverse this trend. Cancer being the 3rd leading cause of death in our country, we need to reverse. And how do we reverse? Now by diagnosing these patients early. And how will we diagnose them early? By going back to the counties and talking to the governors. Let them encourage their doctors and nurses to go out and sensitize patients on what are the common signs and symptoms of cancer. The medical personnel also need to be retrained over and over and just to review, because these patients really sometimes they come to the hospital but the doctor delays in making the diagnosis. So creating more awareness about these symptoms, and when you are treating a patient they're not getting better, what else could it be? Could it be cancer, or is it just an infection?
Okay, definitely a lot of work needs to be done, but the collaboration aspect that you brought out is definitely of importance, because public awareness will play a critical role in the fight against cancer, because in most cases late diagnosis is usually fatal. So allow us to shift focus and bring in our other guest who's joining us via way of phone, Dr. Dennis Miskela, who's the Deputy Secretary General at the KMPDU. I hope you can hear me clearly, Daktari. Perhaps just start and briefly your reaction to the functions being transferred to counties within 60 days. The president gave his assurance that a committee is working on this, and soon after the money will follow. What does this mean from your point of view?
Thank you for having me, Jesse. I think, first of all, as KMPDU, we have always said that anytime the national government intends to transfer any function to the county, they should first of all put the resources, then transfer the function. Any idea where the function is sent down first is a recipe for chaos, and that's the issues you have seen around the healthcare. Because when the devolution first set in, and there was the Schedule 4 and how the function was supposed to be transferred, that was never followed, because for a moment politics took over. And I remember when the former President Uhuru delayed in devolving the healthcare function, there were certain governors who said that he was against devolution, and with that just let the counties take the function. And the biggest challenge we have had with that is that whenever you send that function down there, before the structures being put in place, before the funds being put in place, then the counties are going to be cash strapped. As KMPDU, we have had challenges around the human resources for healthcare. Because we say that even if you build the best hospitals without the requisite human resource, even if you brought the best machines, we had the managed equipment scheme where some of the latest technologies were sent down to the counties, but there were no accompanying human resource to those machines, and those machines don't do anything much to help. So the challenge is for the government to ensure that if we are going to have health as a shared function, because one thing people always confuse is that healthcare is not fully devolved. Healthcare is a shared function, and it's high time the government of Kenya, both national and county, decided to what extent can we devolve healthcare. Because when you devolve from level 5 downwards, then there are certain challenges that inherently arise. For example, how to manage the human resources. You see, governors have an issue with doctors going back to train. As my colleague and my senior said very well, that cancer needs specialized care. You need oncology nurses, you need pharmacists, you need oncologists. But the biggest challenge doctors are now having is that when they apply to go to school to specialize as oncologists, the governors are refusing because they say that they need the doctors on the ground to treat other diseases. So currently we have averagely around 100 oncologists against a population of 54 million. That's a ratio of one oncologist to 540,000 Kenyans. With the cancer now being the number 3 killer in the country, it's high time that we say that the specialized care should be moved to national. For example, our proposal as KMPDU has always been that from the community health promoters to the dispensaries, the health centers level 3, The counties can do a good job running them. They have done a good job in running the ECDs in education sector. Yeah. Then from level 4, 5, 6, which is our specialized care, you can then let national government run. Otherwise, the current situation is like leaving a county to run a university. Yeah. So we have to sit back and agree on to what extent we can do. And the other thing I had also to say that in the management of the cancer, and I've heard my senior say it very well. Earlier this year, we had the cancer conference, and for a long time, we've blamed the patient that they don't come to hospital on time, they don't come for screening on time. And there was a representative of the cancer survivors who said that they're tired of being blamed of coming to hospital late. Most of the time, they turn up early for the dispensary when that woman have that abdominal discharge or bleeding.
All right.
When she's referred to a health center or at level 4, then the diagnosis is delayed. By the time it is being caught up in a specialized setup like a level 5, the disease has spread. And that's the inherent problem when you don't have a proper flow of how patients will be referred from dispensaries all the way up to level 5 or 6.
Okay, well noted. Dr. Miskela just joining us virtually right there, highlighting some of the human resource challenges that are being faced in the counties, even as we share in this devolved function. Dr. Ari, thanks for your time. As we conclude, Dr. Nyongesa, a lot has been said, a lot of progress has been made. You've mentioned of the challenges, but there are equally opportunities that we can grasp at to ensure that this journey towards proper and affordable healthcare is achieved in the country. Your final take as we conclude on this discussion.
Yeah, so we still have a lot of ground to cover as a country.
Yeah.
And this is not a unique challenge to Kenya alone. A lot of developing countries are grappling with the cancer menace. National referral hospitals like Kenyatta National Hospital is quite advanced in this kind of healthcare. We also have KU Teaching and Referral Hospital. So counties should ride on this in terms of capacity building, formulating policies, and also assisting patients navigate the complex system. We know we need to invest, the government needs to set aside a lot of funds to improve the infrastructure, and there are still counties in this day and age which are also quite disadvantaged because they have limited resources. So not all counties are equal, and we need to prioritize and support the weak counties to come up as much as we are supporting all the counties in terms of the infrastructure, human resource, and just focusing on cancer care.
Well, it's a collective journey. Collaboration is of utmost importance. We definitely appreciate your time. Dr. Catherine Nyongesa, the founder of Texas Cancer Center and a cancer specialist, just highlighting the journey in terms of health in the country. We're equally joined virtually by Dr. Dennis Miskela. Briefly, he's the Deputy Secretary General of the Kenya Medical Practitioners and Dentists Union, KMPDU. That brings us to the end of today's discussion right here on News Center. Thank you so much for watching, and trust us to keep you updated on this nitty-gritty details that touch on your